Is it Bataro? Is it some other? Still trying to get in and see what answer I put in there. Okay, let's see. All right, so let's kind of go back to the good job talking about abdominal pain and how to evaluate it and all those type of things. And on that one, I want you to be sure and look at the old cart. You know, that's one of the main things that you zero in on that one is know your landmarks, go back to your differential diagnosis book, and that's what abdomen is pretty much all about, is differential diagnosis. You know, it's figuring out if something is serious or not serious, if I'm going to send them out or keep them. Okay, so know those signs. Know these signs, and you will use these in clinical practice. And I've used that. I really like that heel tap one because it's so easy to remember. It's like jar their heel, and if it hurts, that's positive. So, but you know this McBurney's point, Murphy sign. Those are big ones. And then obturator, you'll use that quite a bit. And this one, iliopsoas muscle test, and the heel tap test. So just kind of go over those again and know what they are, because you will always see those. Okay, and then there they are. I just kind of gave you a little way to, you know, a little practice there. So any questions on the abdominal pain as far as what, you know, how to focus your studies or anything like that? I don't really think that there's much, you know, you got general abdominal pain because so many people have abdominal pain. It's a really common complaint, and it can be so many different things that a lot of the things that you study for abdominal pain, you're studying in other systems, you know, urinary system and GYN, and, you know, you've got all these different problems with that are different things that are in the abdomen that can be causing pain. So, you know, just your approach to abdominal pain, remember old cart, remember your advanced assessments. Okay. And for colic, did y'all enjoy reading the colic section? Did anybody read it yet? I think it's kind of a something that is easy to learn. You know, it's something that a lot of people have experience with. But if you, I put some recordings in here. I think I did a recording at the end of this one. And so just review it and know, you know how to diagnose it. You know, when is it colic and when is it not? And then know your first line. You know, what are you going to tell your patients, and what are the risks of colic? You know, the bonding issues, and also risk for depression and risk for child abuse. So those are kind of the things that go along with colic, and you know, making sure that there's nothing serious, and then dealing with colic. But I don't know if any of y'all have had a colicky baby, but I have, and yeah, I can see how people could get upset. It's very hard because you don't know what's wrong, you know. Okay, so gallbladder disease. I gave you a little recording on this one too, didn't I? Somewhere? Yeah, right at the top. And you know, the main thing is that on this is that if you know the difference between cholelithiasis and cholecystitis, and then you know your risk for it. Who do you expect to see with it? Because you're going to notice that if you are talking about a woman who is 40 years old, white, you know, has overweight, and she's got upper right quadrant abdominal pain, then you're going to be thinking of this profile of this, you know, who gets gallbladder disease. And also know, just because they don't have stones doesn't mean that they don't have gallbladder disease. So if they have symptoms and you're concerned about it, then go ahead and send them out and refer them. Talk to your physician and get the test. And that usually that's the ultrasound. Normally, everybody knows you do an ultrasound. And we also know that the HIDA scan is pretty much the next step. Any questions on gallbladder?
No, ma'am.
These things are not very like sexy, are they? Everybody knows this because there's so much in acute care, but we're learning it from the primary care and what your role is. GERD, I think is a problem. When you get into GERD and you get into H. pylori, those are some of the things that you may not see GERD as a big problem. Because everybody's got it. And, if you think about it, when you're working in acute care, how many patients are on Protonix? Everybody's on Protonix.
Right.
But they know that in the hospital, in acute care, that it's prophylaxis. And so we take it so lightly because, okay, yeah, they're on Protonix, and next, let's move on. Yeah, we got that. But they go home on these meds, and they stay on them for a long time, and they cause problems, and they're also masking those symptoms of maybe something more serious. So if you have a patient that, we know the classic, oh, he's over 50 and he's, has refractory dysphagia and, has dysphagia or refractory GERD, heartburn symptoms, that we're going to refer them. So, but I've heard people say that, after 2 years, or a certain period of time, that you want to repeat it. So I didn't see that in any of our readings. Did y'all see that in any of our readings about repeating endoscopy if they're on long-term H2 blockers or PPIs? But the thing is that if they've been scoped, they're under the care of a GI. And if you have someone who's been on PPIs for 10 years and you say, when was the last time you went to see your GI doctor? And they say 7 years ago, let's say, let's go back again. Because even if they didn't find anything, they'll want to keep a track of these because it can mask other symptoms. So that won't be, that's mainly for clinical practice because you probably wouldn't be asked how to manage a patient who's already under the care of a GI doc. But for clinical management, you want to make sure that you stay on top of it and just don't let them keep going and going and going. My husband was on PPIs for a very long time. And he has had 2 pathological fractures in 2 years on his feet. And it's directly related to that. But he had the Nissen fundoplication, and it worked really well, and he's off of them. But he still has osteopenia and osteoporosis.
So I have a quick question regarding proton pump inhibitors. Because I understand that, like you said, it's for short-term use, not long-term use, and a lot of patients get on them. However, I know we do like the upper GI, that's normal, like today I had a patient in clinic with that, and he had a normal GI, but he complained of, upper GI series, and then he had dyspepsia, and he was complaining of heartburn, of course, and so we ended up starting him on a proton pump inhibitor. The long term on that, within 8 weeks, I would follow up with him and see if he's still having symptoms, and then if he is, then I would go for the EGD.
Well, we don't usually order the EGD, so we would refer them to GI. But yeah, you'll start him on a proton pump inhibitor. Odds are he's going to feel better. Most of them feel better, and then you try to get him off of it. See, we schedule a follow-up, try to get them off of it. If they can't get off of it, it comes back, it's refractory, then that's when you're going to refer. Go ahead and get them scoped. And upper GI is not going to show so much, the esophageal erosion and things, the Barrett's, because when they're in there with the endoscopy, they can do the biopsies and things that they need to do.
The upper GI is like for the high hernia problem.
Yeah, I think it's CT. Well, they can see if that valve is incompetent, and they can see that on an endoscopy, and then they'll do CTs and see. Like my husband, he had a huge hiatal hernia, and his stomach was sitting behind his heart, and he would wake up choking, and I thought he had sleep apnea, but it was reflux in the nighttime, and it would just go straight. There was no valve at all; it would just go straight up. So he had really, Dr. Ortiz in Corpus does those, and he's just, I can't say enough about him. And it's not like, and people used to think Nissan fundoplications are really, really bad and, you know, fraught with complications, but now they do them in, you know, with scopes. And so it's not hugely invasive, and he does them quite often. So if you're in Corpus, but they would go to surgery from GI. As a primary care provider, it's good to kind of know what the course of the history of the disease and kind of what to expect. But their GI would refer them to surgery. That wouldn't be something that you would have to be concerned with. So, okay.
So what do you want us to know then about this?
I would think, you know, when to refer, the risks of PPI, you know, and the typical person that you might see, you know, those things when you look at that form right here, kind of here. And a lot of times in these abdominal problems, you're going to get to probably about here, number 8. You know, with GERD, you're going to get into the pharmacological and non-pharmacological, and y'all did a really good job of pointing out, you know, the weight loss, the smoking, all of those things that are, you know, it's lifestyle, right? And but with like appendicitis, you're going to stop at, you know, if you're a differential diagnosis and your most likely diagnosis is appendicitis, you're done at 7. Your management is send them out, right? And you know, infantile colic, you can go all the way through. Gallbladder disease, kind of the same thing. You may get into ordering, you would, if it's not real acute, you would order your ultrasound and all that. But if they're in a lot of pain, they need to go ahead and go be evaluated in acute, you know, at the hospital, because they need pain control and whatnot, and they can be. But usually with gallbladder disease, you can get probably some of the workup done, but you won't be doing the management and things like that, you know. Well, I don't know. I have some patients that have gallbladder disease that haven't had surgery, and they have their gallbladder, and they're not candidates for surgery because of their age. And so with them, we just kind of manage it, you know, with diet and whatnot, and they keep living. So GERD, you know, you want to go pretty much all the way, you know, and to referral. You know, you want to go through all the way through it to referral. And then with hepatitis, you're going to see a lot of those. Did anybody read about the non-alcoholic fatty liver disease? That is, you're going to see that a lot. You're going to see these people that have slightly elevated liver enzymes. And you'll think, oh, it's their Lipitor or their statin or their drinking. No, they probably have a fatty liver. And it's you know, I have a fatty liver. I'm not overweight, I'm on the border, but I have a fatty liver. And there's just people that I have hypercholesterolism, so that fat is depositing. That's the way it was explained to me in my liver. But it's from obesity. It's fatty deposits, you know, visceral deposits of fat. And so I'm not heavy alcohol consumption, but maybe I'm thinking about it, right? No, I'm just teasing. But and it's bad. You know, at this time of the semester, I think everyone's getting tired. At the end of the semester, everybody's kind of, everybody wants everything now at the university. You know, you got to get it done before you leave and take your break. So, but not NASH. It's called NASH. And it's a risk factor for you get hepatitis and you get cirrhosis of the liver when you're not an alcoholic. And that's serious, right? From what I'm understanding is that, you know, this can progress. Did y'all read the natural history? It can progress, you know, over a 10-year period. It doesn't take that long. So if you have people, go ahead. Is there a question? Does somebody have a question?
No, ma'am.
No? Okay. Okay, so if you have a patient with those elevated liver enzymes, and then it's not, you've done your look for hepatitis, and that's negative, and you've done that little workup that you need to do when you have elevated liver enzymes, then you're going to do an ultrasound of the abdomen, and you're going to probably find this. So you can see disease progression here. Does it say the number of years? And there's cancer. So we know that cirrhosis leads to cancer. That's a risk factor for cancer. So, and how did it say how? It says the risk of hepatocellular carcinoma among those with cirrhosis range from over 7 years. And so it is rather rapid. And so in these people, you want weight loss, but it's everything requires weight loss, right? Are we losing weight? I'm not seeing it too much, but we can all, I don't want to get discouraging because, sometimes it does feel like we're preaching that all the time, and so there's the weight loss. You've got that, and general approach, weight loss. You want to get them vaccinated. You want to keep their liver healthy. You want to, you're going to get their lipids under control. And pharmacological, you're going to pioglitazone, which is it's going to be an insulin sensitizer, and it's going to give them heart failure too while you're at it. Yeah, and so they want to avoid alcohol, and so this kind of gets a little bit more. They're suggesting some of these other treatments, but the main thing is that this needs to be on your radar for patients that have elevated liver enzymes. And there are things that you can do to try to keep them a little bit, to try to, stop the progression. And one of the main things is no alcohol, keep them from getting hepatitis, treat their lipids, their diabetes, all of those things that are inflammatory. Okay? So I wanted to be sure and point that one out because it's not something that, I think is oftentimes in the textbook. Was it in Bataro? I haven't read that chapter this semester because we're not using it that much. What did y'all see that in the non-alcohol fatty liver disease? Okay. I'm looking for I'm trying to get back to my topical outline so we can make sure. I want to get through, just kind of talk about those a little bit. And we can meet again. Y'all's test is a little ways away. And we can meet again if you want to, before your test. I know that you didn't have a derm review, and so I didn't teach that section, but I'll probably be helping with that derm review. So y'all just let me know, and we can get together again. Okay, so hepatitis. Okay, know your levels on hepatitis, and go through that list of the things that that you're going to know about these, the risk factors, how you're going to, do your testing, and then refer, right? Now, with, a lot of them are self-limiting, and when does it become chronic? When do you have a chronic hepatitis? And what does that lead to? And hepatitis C, y'all know who the famous person that had that is. It's the Naomi Judd, right? She had it. Or has it. I think she's in remission. There's some really good treatments now, but they're expensive. And then another one was, did y'all ever hear of the show Dallas? Y'all are kind of young, but Larry Hagman. Do you know that Larry Hagman had it, and he actually got a liver transplant, which I thought was unusual because, people that drink a lot and have hepatitis C don't normally get the liver. I guess it depends on how much money you have. You can get a liver these days. So, and then pancreatitis, like I said, what I put over here, Bataro is a good resource. If I put that in this section, that means Bataro is everything you need to know because there hasn't been any changes. And it's usually a little easier to read and more condensed, it's a little more concise. Evaluation, diagnosis, and referral only. So most of these patients go to the hospital. but you need to be able to evaluate them and, know when to send them out and, what the risk factors are and who are you looking for. Who are you looking for? And then peptic ulcer disease, I think, that the H. pylori is in there. H. pylori goes right with that. Almost, what was the percentage? 90% of people with peptic ulcer have H. pylori. Was that what it was? Something like that. And so know how to treat it, and we've talked about that a little bit in classes. Nothing really earth-shattering there. And know how to test. Now, usually, we get the serum test, and that can be positive for 18 months, 2 years after treatment. So
what can be positive?
Yes, the serum can be positive for a long time after treatment. So that's a problem. But most time we get serum because it's cheaper and easier. And the urea tests and things, you have to usually send them to the lab for that. But where does it say that about how many people? I don't think this one has the epidemiology diagnosis.
It was in Butaro, I think.
Yeah, and I think it's in one of our readings too. Because you have the natural history, the overview, and it might be in there. But it's they pretty much found the reason for peptic ulcers when they discovered H. pylori. It was, how people lived with those for so long before they understood this problem. So know how to treat, know how to diagnose. I think the thing where you do the urea, where you blow into the, they're testing your when you blow into the thing for urea. I think that's what it is. Eradication, we have to look at diagnosis. That's what up to date is kind of difficult because, if you read Butaro, it's all there, in one resource, where in this one you've got to look at diagnosis and then go to another article to see management and maybe even another article for natural history. Okay, so let's get down to the testing. Upper endoscopy test for H. pylori. So they're talking about biopsy to test for H. pylori. How often does that happen? But oftentimes, if you have a patient with an ulcer, of course they're going to get an endoscopy. So, and then they're talking about stool, right? Stool, and I've never done one of those. 4 to 6 weeks. So let's see. Breath test, urea breath test, and stool antigen test. So you can do serum, and it's easy to get, and it's pretty cheap. And I think have y'all done any clinics where they do this? I think I've seen it done, but usually we send them out, to the hospital, not to be admitted, but to do it there because they have the equipment to do it. Okay. All right. So any questions on that? There's not a lot to say about that. Oh, with gastric ulcers and duodenal ulcers, look at the difference in presentation, because one of them starts 2 hours after a meal. And one of them, I think, let's look at the differences in there. Peptic ulcer disease, clinical manifestation, and diagnosis. Do y'all know which ones those are? What's the difference there between what you're going to find? Peptic ulcer, dyspepsia, pain, bleeding, perforation. I'm like y'all, I just want it to be just right there, so easy to find. Okay.
What did you say? You said to look at something in presentation between gastric and football.
Yeah, peptic ulcer. When do you have the pain in association to food? And in duodenal ulcer, when do you have the pain in association with food? And so if I put in duodenal ulcer, I'm getting the same thing there. It's probably in Botaro. I can't, that's bothering me, and I want to say what it is, but I'm afraid I'm going to be wrong. So I don't want to say it out loud, because I'm like, oh, Dr. Day, she doesn't know what it is. And yeah, I don't know everything, yeah, that's for sure. But I read it, and I deal with it, but I have to look things up if I haven't, I'm getting old, I guess, so.
When I was reading in a Paso book, it made it easy to kind of think of where it was, because in the duodenal ulcers, the duodenum was part of the small intestine, so it doesn't occur with food, because that's not what's going on. The one that hurts with food is the peptic ulcer, because it's coming from your stomach, so when you're adding food into it, that's when it's hurting.
That'd be good. So yeah, I'm thinking, for some reason I'm thinking when the food comes out, gets to the duodenum, it hurts then, but let's see. Although some patients are asymptomatic, the most common presenting of epigastric pain, 1.5 hours after a meal, 1.5 to 3, or in the middle of the night. So is it, and think about, is it relieved by food? Is there any relief when you eat? So those are the things we need to look at. With the report that pain is relieved with the ingestion of food or antacids, however they're current. So, when the stomach is empty, it's going to hurt. If you have a peptic ulcer in the stomach, when the stomach is empty, it's going to hurt. Food may make it feel better, and antacids. Okay, so that makes sense, right? That makes sense that there's nothing in there to soak up the acid, then it's going to hurt. And that's all that's there on that. But for some reason, I'm thinking that you could be right on that. Be sure and look at, and if y'all find it, if there's anything on the duodenal, when do they have pain with the duodenal ulcer? Let's see. So be sure and look that up, and because I'm thinking the stomach, you're going to remember that because the stomach is empty, so now the acid can get to the lining and it's going to hurt. So an antacid and eating will usually relieve it, but it will come back. That's what I just got out of that, okay? If you got the same thing. Okay, so peptic ulcer, epidemiology, and then natural history. So there's quite a bit in there, quite a bit and up to date on that. But those are the key things in diagnosis: is when the pain, where's the pain, what makes it better, that old cart stuff. That's key to that. And pyloric stenosis, just go ahead and read that. There's not a lot to, that's the one where there's a grape, right? There's a infantile hypertrophic pyloric stenosis. You're gonna, look at the, just all the things there, and let's see. Do y'all have any questions on that one? Have y'all read that one? Okay, pyloric stenosis. Let's see if there's anything, clinical manifestations. So this one is the one that there is some, there's going to be some, they use the same immediate postprandial vomiting. This is not the one where there's a grape olive-like mass right there. Okay, remember I put in there, I don't know if y'all saw it, but I put my brain in there that I wrote when I was a nurse practitioner student. And in there was the dermatology keywords. I would call them dermatology keywords because you always see the same words to describe that problem. So look at that if you didn't in the dermatology, or I think it was in the main discussion area. And but this one with pyloric stenosis, you've got an olive-like mass. That's going to be the, that, and I was saying a grape, but it's an olive. So whenever you Whenever you see olive-like mass, you've got pyloric stenosis. Okay, so you've got projectile vomiting in a 3-6-week-old. Okay, and that's the only thing I've ever seen on there is that olive-like mass, you know. And so what are we going to do about it? Clinical associations evaluation. I'm probably going to ask someone to, I'm probably not going to keep this person. Okay, so palpation of the olive, other physical findings, laboratory testing. So if they're ill appearing, it makes a difference in what their clinical condition is, right? This isn't a recipe book. We're always going to look at the patient and see what's going on. So if they've had a lot of vomiting, you're going to look at electrolytes, you're going to look at kidney function for dehydration, CBC, bilirubin. So is this getting into pretty much specialty care there? You've got a patient that sick that you need to draw electrolytes on them, they're going to the hospital now. Because you don't want to keep them, infants 3 to 6 weeks old can really go bad quickly. We have any pediatric nurses on? They can go bad quick. And so, especially with electrolytes. So if you've got somebody that's, you know, vomiting and they look sick and they look dehydrated, they're gone. They're not going to stay there. Okay? And so if you have one that doesn't appear that sick and you're suspecting it, it's a definite you know, consult with your physician. And you know, if you work in pediatrics all the time, you can probably manage this, but I think it's probably time to, you know, get some, you may order an ultrasound or something, but you need to consult with them. Okay, but this stuff like target sign of transverse view and all that, don't go into that because that's really kind of specialized information. You just need to know when it's a problem. And this is the differentials, you know, got gastroesophageal reflux. And I mean, I've seen more often lately that babies being put on Pepcid, which I didn't see before. And you're going to look at cow's milk protein intolerance and adrenal crisis. I've never seen one of those in a newborn. And intestinal obstruction, liver disease. So those sound pretty serious in a newborn. Anything, you know, anything like that in a newborn with liver disease, you know, obstruction, adrenal crisis. Those sound bad. I don't want them with me. Okay, so you wouldn't want to go into the rest of that. You wouldn't want to go into these, you know. Conservative management is usually after they've seen specialty. You know, they decide not to do surgery, and now you just happen to have this patient that, you know, you have in your clinic, and he's also got this problem that's being managed by somebody else. Yeah. Okay. And I'm wondering why, are y'all getting that on your screen too, where it's kind of showing half of the document? Here we go. Whoop, I went the wrong way. Okay. Topical outline. Kind of showing half of it, but if I click on this thing, it opens it as a web page. Okay, hemorrhoids. You know, I know people that remove hemorrhoids in the office setting. If they're external hemorrhoids, and especially if they get strangulated, you know, they're not draining. I've seen them remove them, but they put, you know, you can put little rubber bands around them. You can do different stuff. I don't do that, so I'm not sure. So treatment of hemorrhoids, I'm sure y'all know quite a bit, but you're going to look at the difference between, you know, these anorectal, you're going to have people that don't want to talk about this, and but you have to look. You know, you're going to have to look, because an anal fissure, it's very clear. You know, if it's bleeding, and people will think they have hemorrhoids when it's an anal fissure, and an anal fissure will continue to open up, and it's usually from hard or large stools. And so you want to keep them real soft. Just keep them, you know, all those things that you know, and those things that you. I've seen some people with anal fissure that they because of the pain in the rectum, they will get contractions of the rectum, you know, that muscle right there at the anus. And so I've seen them actually get calcium channel blocker cream put on them by the specialists, but then they ask them to do sitz bath like 4 times a day and put this cream in. It's like, yeah, right. Who's doing that, you know? And so stool softeners, you know, they work for some people and they don't work for some people, but, you know, do everything you can to keep those, you know, those clean, and so that you don't get into the abscess. Have you all seen patients in the hospital with anorectal abscesses? That's always a, you know, that's always a mess because they have to be packed, and it, you know, it's a big problem. So keep everything clean and dry and refer out. And the anal fissure goes to, you know, there's not really a lot they can do about it, but you can send them to colorectal surgery and have them looked at it. And they'll, you know, those are the ones that usually give them those crazy treatments, but that they don't follow. Okay. So appendicitis. Okay, that's where you're going to memorize those exams. And in children, it's not always, you know, it's clear cut. I remember I had a 12-year-old, and usually in little children it's worse, but I had a 12-year-old, and you know, we treated for UTI, and she came back again, and she just looked like she was sick. And she wasn't feeling well, and both of her parents were there with her. And I did that heel thump. She was laying down. I didn't have her stand up. I did the heel thump, and I whacked her on the bottom of the heel, and she grabbed her abdomen. And I was like, uh-oh. So that was, but in smaller children, you're not going to see it really in tiny babies or anything, because it takes a while for that, you know, to develop. And you don't see it a lot in really older people. You know, you'll look at the incidence, you know, the kind of person you expect to see it in. So appendicitis, do y'all feel comfortable with that? Is there any questions on appendicitis, on exams? And you know, you're going to go through number 7, right? Go through number 7 and send them out if that's what you suspect.
I have a question.
Mm-hmm.
I kind of had problem with this on my last exam, but say if I see, I do enough assessments and I am thinking that it's appendicitis, at what point I had problems differentiating between referring them straight to the ER or acute care setting or consulting with a physician. I still have at what point do you consult with a physician?
Well, the difference is with appendicitis is that there's no outpatient management, basically. So that's where you're going to have the difference, is that if it's a problem that is managed conservatively as an outpatient, then you would want to talk. And you know, it's up to you and your physician. But if it's clear to you that you're suspecting appendicitis, then you just send them out. And you can talk to. I would always talk to my physician. Most appendicitis patients are not going to have a diagnosis before they arrive at the emergency room, because you can't do the CTs, you can't do the testing. And so with a DVT, we often already know they have a DVT before we make a decision about what we're going to do. And so an appendicitis is an emergency situation. It's considered a surgical abdomen, and you would just send them out. And there's no real direct admits with appendicitis. I mean, I haven't seen many. Usually they just go through the ER. So, yeah, unless your physician is at the ER and can see them there or something. But, yeah, I think that's the difference, is when you have something that can be managed outpatient. Then it's a decision whether, if this is a big enough problem to keep them here, you know, or to send them, or can we manage them outpatient? And you can't do that with appendicitis. And usually, you know, pancreatitis, they're in so much pain, you know, but like an anorectal abscess, we'll have to look at that more closely, but that might be an example of something that might be managed as an outpatient or an inpatient, depending on if they need, you know, IV antibiotics or whatnot. So any other questions on that one? I hope I was able to clarify for you, to just kind of know the difference between what can be managed outpatient, what needs to be inpatient. And then colon cancer, you're just going to really know the screenings, know that. And there was, you know, how do you screen them? How often? And if you do one method, and when do you, like if you do stool for occult blood, you have to do it every year. But if you do a colonoscopy, you do it every year, every 10 years, right? Because cancers are slow growing. Please tell me I'm right, because I read the book, but let's see. Okay. Fecal occult blood testing beginning at age 50 and continuing to age 75. Okay, so they don't want you to screen over 75 years of age, but everybody after the age of 50 gets screened. And then are we going to screen anybody before the age of 50? It's not saying it in here, but I'll bet we'll find it somewhere else. If they have a family history or, you know, a clinical indication, then you can always do screening. But let's look at I wanted to look at those, where's up to date? Oh my goodness. I want to find one that's real. Okay, there we go. And we're going to go colon cancer screening. And the only real two ways that I've seen it done is in with you know, the occult blood, the stool for occult blood, and with the colonoscopy. But they list another one. What is the other one where they do every 5 years they do some sort of, but that's not real common. So where is it? Did y'all read this?
They do what?
Pardon?
They do what?
Test used for screening. Here we go. Fecal occult blood test, Cologuard, endoscopy, flexible sigmoidoscopy, that's your colonoscopy. Optical colonoscopy. So do they tell the dates how often they do them? So a colonoscopy is every 10 years. Fecal occult blood is every year. But this other kind, right? Have you seen people have varium minimas for screening? These are all options. These are options. And is the CT colonography, is that the one where they swallow that pill and it goes through, it has a camera and it goes through and takes pictures all the way through? But usually, you know, if you want your patient to have a colonoscopy, you send them to the GI doc. You don't order a colonoscopy, you send them to the GI doc and they evaluate and then they do it. You know, they do it there. I don't usually, barium minimas are pretty nasty. They're hard to tolerate. And so I've never ordered one for screening. But I guess that is something that a nurse could order. And you could do that, but, you know, colonoscopy is clean and easy because you send them out and they come back. So kind of know the different screenings and know the USPSTF recommendations for when to start and when to stop. And it doesn't mean that, you know, if you have let's say that you have an 80-year-old person and he has abdominal pain and a fecal occult blood is positive. Well, that would be a GI bleed. No, what I'm trying to say is that if you have somebody over the age of 75 that has risk factors and you suspect something's going on, refer them and for colonoscopy, and it would be diagnostic rather than screening. You know, we don't not do a colonoscopy because somebody's old if they need it. Although they probably wish we wouldn't do that. Okay, so here's the USPS guidelines, and then here's where they differ. You see how they list that. But USPSTF, it usually goes, and the CDC will probably be very similar to this if there's anything there. And this is kind of mainstream. This is like your minimum screenings, and this is what you need to know, the USPSTF. Okay, but there is, you know, evidence for, you know, starting earlier, you know, depending on race, all that kind of thing. But I don't think you can really learn all that for now. And, you know, later on after you have your license to learn, when you graduate and get your license, you'll get more into this stuff, especially when you deal with it all the time. You might make a decision that I'm going to follow these guidelines. And these guidelines have NSPS there. This is the minimum. NSPS-TF is the minimum, and then this is a little bit more elevated. These usually have more frequent monitoring. So you'll see that. I like the way that UpToDate does that. They kind of go through there and tell us, you know, what the differences are. Okay. Okay, constipation. Review your drugs. Review your drugs and just look at those and you know, there's not much there. Diarrhea, you know, when do we stop it? You know, the approach to adult with acute diarrhea, and you know, you're always going to look at the hydration and all those. Look at kids. You know, that type of thing. Any questions on the diarrhea? I don't really have much to, you know, you know, this leads into acute gastroenteritis, and you hear about that a lot. And I'm not sure that that was in our readings. Is there even something, is there even an article on acute gastroenteritis? Okay, let's look in children. Viral gastroenteritis. So I think that Bataro has non-viral diarrhea, and gastroenteritis, you know what, I really wish that we would have, I might put a little something in there about it, because, you know, viral is, you're going to see that all the time, and I think that it was left off and it shouldn't have been. So this is prevention and treatment. Water for purification. I'm just trying to see if there's anything. What is typical of this one is fever. That's what you're going to see in viral versus non-viral. Unless they are dehydrated, they may get a low-grade fever, but usually with viral, they're going to have a fever. So, and you're going to go through all of the, you know, all of the things that have to do with fluid loss, and then figuring out if you're going to refer. Okay, so this is a child, when to refer. It's based on their condition. So more than 7 days, they look bad, severe hydro, you know, all of those. It's mainly to do with fluids and electrolytes. How are we going to treat them? If it's acute, they're going to get, you know, hospitalized. But you're going to do the fluid resuscitation, and we try to keep them at home if we can, but it depends on their age. If they're real tiny, they're going to probably end up in the hospital. So antidiarrheal agents. Diarrhea is, you know, it dehydrates people, so you might want to stop it if they're you want to stop the diarrhea if they're getting dehydrated. Sometimes, you know, they don't work real well for people, you know, so you're just gonna, but usually they wanna something. So you've got the Pepto-Bismol kind of thing, salicylates, but remember with children that is, you know, Reye syndrome. If they've got a flu-like symptoms, you want to kind of avoid the salicylates. And did you know that Pepto-Bismol turns your tongue black? So that's always fun when they complain of that. We got lactobacillus and those kind of things. But this wasn't in your assigned readings, but I think the difference between infectious and non-infectious diarrhea would be the fever. You're going to see the fever, but I don't think there's a question on that. I just, for your own, I know you see it all the time, and I just want to make sure that that we kind of cover that a little bit. I'll put something in the discussion forum on that. Okay. Diverticular disease. Can you eat seeds with diverticulosis? Now, how many patients do you have that tell you, I can't eat tomatoes because I have diverticulosis? The seed thing was huge, and it's really not evidence-based anymore. It's more of a tradition. So diverticulosis means that they have the pockets in their intestine, and diverticulitis means that they're infected. That's the difference. Diverticulitis, usually they need IV antibiotics. It's pretty serious. Well, I've seen, you know, we've treated diverticulitis outpatient with 2 antibiotics, but it wasn't, they weren't getting a lot of peritoneal irritation and whatnot. But, diverticulitis, the big risk is that those things will rupture because they're infected and pus-filled. And so you want to be pretty aggressive, and it's painful. It's painful, and they don't, they don't really eat much and all that. But diverticulosis is a very common finding, and they find it on, postmortem. They find it on incidental all the time. So this is another one of those where you can replace the assigned readings and know your antibiotics for treatment for outpatient, because you will manage some of these outpatients. Okay, have y'all heard, I didn't see this term oncoparesis. Now they're calling it, have you heard of that before, where they'll hold their stool, they don't want to stop playing or whatever, they hold their stool and then they are incontinent because it just comes out? But now they're calling it fecal incontinence in children. They're not using this oncoparesis, but I put that there in case, it's something you recognize. And so, it's really constipation, and it's really the root cause of it. So go ahead and read that. People, that one is easy to learn, okay? I think it's worth your time to learn it, and you're going to see that in practice. I had a little neighbor kid that he was 8 years old, and he had stool in his pants, and he was your classic oncoparesis. He didn't want to stop playing, so he would hold it, and then it would come out, and he still wouldn't go home. It's like, go home, kid. Go talk to your mom for a while. But, he was fine. He just would do that, and it was bad because of the social ramifications, because there was an odor. Okay, so inflammatory bowel disease. Now, that's the... that's Crohn's, and what's the other one? Crohn's, and I forget what the other one is. You guys know it. You're the smart ones. Okay, let's see. We need to. As far as those, they're always those inflammatory bowel disease. They're always in. They always have a specialist. So you will see these patients, you'll have them in your clinic, that it's ulcerative colitis and Crohn's disease. So they always have a specialist, but you may be the first one to see them. So you need to take this up to number 7, and then you will have these patients in your clinic that you'll have to co-manage. And so outpatient management, you'll want to kind of zero in on those. Those aren't biggies, they're kind of need to be on your radar though. I don't remember a lot of those on the test, but now the thing that, really you'll see a lot of is the irritable bowel syndrome. Irritable bowels here, and you'll see that a lot. And everybody thinks of irritable bowel syndrome as diarrhea. And you'll probably see more patients with constipation with irritable bowel than you do with diarrhea. I do. And so, know how to treat that, know what it is. You want to differentiate between, you're not going to have any blood in the stool, things like that. But so read a little bit about irritable bowel, and probably mainly because you're going to see it a lot, and it's kind of like the NASH, the non-alcoholic steatohepatitis. You'll want that to be on your radar for your clinical practice, because you see it so much. I mean, it's just because of the obesity, you'll see that quite a bit. Nausea and vomiting, know about your approach to that, and the meds. When do you want to stop the vomiting? It's, you're going back to, again, pretty much, here's viral gastroenteritis in children. Oh, thank God. I was like, did I leave that off? Okay. So there's not a lot of difference between, children are just more dangerous because they get dehydrated so much easier. That's why I just had you read that one, but there's, it's kind of the same principles. So I just had you read about children. Okay. So that's about, there's not anything real earth-shattering there, and people usually do pretty well on this test. And so I'll probably put up some GI discussion questions if I don't, bore you to death with them. So we can talk a little bit, and if you have any questions, be sure and, ask them. And are y'all going to want another session before the test? When is the final? It's a long time away, isn't it? I don't know.
the
You
week
can,
before?
you can, pardon?
Maybe the week before or something?
Okay.
I think
So it
everybody's
is
trying to
the
catch
12th.
up.
Yeah, we can do something, and I'll get something from Dr. Miller on, he won't be available then. I'll get something from Dr. Miller about derm. And did he put up any questions, review questions,
Yes,
like he does for his chats?
he did.
Did y'all see anything? Huh?
He did. He gave us
Okay,
questions.
good. Did it, but he didn't have a chance to go over them? Okay, so I'm gonna review that section. I hate derm, but I have to do it anyway. I have to do it in clinical practice, and you know, to me, everything looks alike. You know, it's like, what? So, but I have a little, have y'all seen what Amelie Hoyer has on her website? It's like paint chips. Have y'all seen those things? It's a, you know, you get Sherwin-Williams. And it's a huge thing, and it's just like Sherwin-Williams paint chips, and it has all kinds of pictures of the skin. And then on the back is how to take care of them. So you'll have a whole one with atopic dermatitis. There'll be 7 pictures of people of different color and different skin ages, and then on the back it tells me how to take care of it. So I can move along there. But what I was telling you about in the discussion section, you want to learn these for derm. You'll want to learn those key terms. Was it right here? What Dr. He put it right here. Dr. Miller put something right there, and then I put in my little book, my brain that I wrote. But the reason I gave you this page is because this is how I remember, you know, because you'll see these on the test. You'll see bullseye lesion, Christmas tree pattern, salmon-colored oval plaques, silvery scale, psoriasis, always psoriasis. When you see these words in relation, you know, you're going to want to be able to describe lesions that you see in clinical. And that how they're described, you know, medically. This is how we see always, you know, we would say Harold patch, burrows, scabies, and, you know, so you'll learn these little key words here, and then anytime you see them in the future on a test, you'll know what it is. You see pearly dome nodule, think basal cell carcinoma. You don't need to know anything else, you're dead. No, but I'm not real big on pictures and stuff, but I think there will be quite a few pictures on his test. So we'll kind of review everything and go from there. Anything else?
No, ma'am.
Okay, well, I'll get you a date before the test, okay? We'll try to do it Thursday.
So,
All right,
great.
thanks for coming.